Professor David Jones from the University of Newcastle Medical School. He's the Pro-Vice Chancellor. He's also the expert on primary biliary cirrhosis. And as far as you can travel, you won't find anybody who knows more about PBC than David. And he's been a friend of LIVErNORTH right from the start. And he's one of our medical advisors. So I'm going to hand you over now to David, who will give you a little chat. What he's called this is a fireside chat. So there you go. All right. Thank you, David. And thank you so much for giving us your time.
Well, thanks, John. Yeah, fireside chat without any fire. That was actually invented by one of the American presidents. So when they were sort of talking about the Cuban Missile Crisis, things like that, they do it in the form of a fireside chat, which is a slightly strange way of doing things. So what I thought I would do is that, rather than put little slides up and things like that, what I thought I would do is oh no, you lost my view of the world because I was muted. How terrible. It's the curse of Zoom. So I don't think you heard any of that. So it's lovely to be here. The fireside chat without a fire. It's just, I thought, rather than do some slides, which makes it all very formal, what I do is I talk through some of the things that I'm being asked about all the time by people. Some of the things about what I think is going on, what I think is about to go on. And then I'll talk about some of the exciting stuff in our world at PBC and AIH, and then just sort of where I think some of the things are going in the future and some opportunities for everybody, but also, you know, some of the challenges that we all face. And then happy to take questions on pretty much anything. Obviously, as I once said to somebody who said, aren't you obsessed by PBC? I said, no, I'm interested in all forms of autoimmune cholangiopaty. So that's PSC as well. So I'm a generalist. So as we get away from PBC and AIH and PSC and transplantation, I know less. I've heard of NASH vaguely, but not sure what it is. So I will try and answer any questions that people want. So please do forgive me. I know a little bit about what I know about, but I'm honest about what I don't know about. But I think there's a lot of general themes going on. So everything I say is a personal opinion. So please, it is a time of febrile differences of opinion. So this is my sort of personal opinion as to where we are. I'm an immunologist by background, so I know a little bit more about immune system. I'm not an infectious diseases person, but I've been a clinician in the NHS for 32 years now, so I know a little bit about how hospitals work and things like that. But please, this is not the view of the Trust in Newcastle. This is not the view of Department of Health where I work. Part of the time, this is a view from me, because I think that's what people are interested in. So COVID, where are we at the moment? So the answer is that if you look at our hospital, or you look at Gateshead Hospital, or you look at any of the other local hospitals, what they're seeing is a slight increase in the number of people being admitted, but nowhere near how it was in either early 2020 or the first 3 months of this year. So the numbers are going up, but they are not anywhere near what they were, and the system is nowhere near being under significant pressure. Okay. The second thing to say is that if you look at the really sick people, we are seeing a small number of really sick people, but it's a very small number. I was on call at the weekend at the Freeman, and we had 3 sick liver patients there, but the critical care hadn't, on critical care, but critical care had no COVID patients. So that's an important perspective. And I think the figure of this week is that COVID is the 18th commonest cause of death in the UK. So there are 17 causes of death that are commoner. So that's a perspective on it. So it is an issue for us. It is not a major issue at the moment. The numbers of cases being identified out in the population, you can see the figures like I can, those numbers are very high, but it is very clear from the figures that what we're seeing is a much lower likelihood that any person found to be positive with COVID turns into somebody with COVID illness in hospital. So that is the impact of vaccination. So, so that is important to say. We are seeing far fewer significantly ill people, and where we are seeing them, they are typically people who've not been vaccinated when they were in a group who could have been vaccinated, but they are particularly in the space of people who are overweight, people with type 2 diabetes. So you'll hear a lot of talk about comorbidity and risk factors for bad COVID disease, and it is very in certain specific areas. So we are not complacent, but you know, I've been through the first wave and been through the second wave, and it doesn't look or feel at all like that. And largely the people who are getting COVID are younger people for whom the illness is less severe as a disease. And as a general observation, this is again a personal view, this has all got too politicized for me. So a lot of the views that people take are along fairly dogmatic lines. There seem to be two things that have worked in COVID in general. One is locking people away so they don't encounter anybody with COVID, and the other is vaccination. But long term, we can't have a society where people are locked away. And so eventually we have to live with this in one form or another. And so people being exposed to it and developing immunity to it or being vaccinated is the way we'll get out of all of this. So the numbers of tests that are positive don't unduly worry me, as long as the connection to people being ill isn't there. And that's the way we are at the moment. So steady as she goes. Now, liver disease and COVID, very interesting. Very interesting indeed, and certainly in my own areas, is that we're seeing almost no impact in liver disease patients, okay? To infectious disease, they are, but in terms of COVID, we are not seeing, in none of the weeks that I've been on call, have we seen anybody with liver disease and COVID. So I'm sure there will be some, but we are not seeing an issue, and certainly we've not seen it in the patient population that Jess and I look after with PBC and AIH. In fact, I'm yet to see a PBC patient with COVID. So that's interesting. So what that tells us, it's not scientific, there is some data on it all. I think the official view is that we don't know. I think my view is we sort of do know, there isn't particularly a problem. The one exception to that is people with advanced cirrhosis, and that's true of all liver diseases. So having cirrhosis weakens you physically and it weakens you immunologically. So I think the group that we are worried about are people with cirrhosis of any cause, but we are not seeing any particular signal at all in our patients. People may remember that there was some talk a little while ago about a gene that predisposed people to bad COVID. There's been a lot of research, some of it very high quality, some of it less high quality, and that's not been followed up. But it is interesting to us that the gene that was implicated in COVID is a gene that is implicated in PBC, but it's implicated the other way around. So the form of the gene that is associated with an increased risk of PBC is associated with a decreased risk of severe COVID. Now, I'm not saying that PBC protects people against COVID, that's just a kind of observation that's out there. But the only evidence we've got of any of the pathways of PBC and crossing over with any of the pathways of COVID is something that could be protective. So it gets, you know, complicated with all of that. So PBC and COVID, we are eternally vigilant and we watch out for it all the time, but we aren't seeing a particular problem. Now, there is an issue, obviously, with COVID and liver disease, PBC and AIH, you know, is obviously one of them, is around how we look after people. And this is where there's a very mixed story. As people will know, in our clinic, Jess and Kath and the team have done a phenomenal job keeping the clinical service going, and I pay absolute credit to them. And we have operated throughout what we call a blended service. So we have never stopped seeing people face to face where that was the right thing to do. And in fact, have refused to stop doing that, despite being told we had to. That's Jess for you. You know Jess very well. Jess told them where to get off, all power to her elbow. So we've continued to see people. But on the other hand, there are people who don't want to come in. And so we've been offering, telephone consultations, but it is to a significant degree up to individuals. We've also done, and there may be people on the call who filled this in, we have done a survey of our patients as to what they think about it. And the answer is, as we would expect, which is there are some people in some situations where actually it's much more convenient to get the bloods done locally and then to do a phone consultation. So I think moving forward, what we're going to do is offer that opportunity. And I suspect most people will come to the clinic at least once a year, but for interim visits, particularly where people live a long way away, it will be convenient for them to have that follow-up done like that. So we see it as something that just changes the offering for us. And so, but we will largely leave that in the hands of people as to what they want to do. Blood tests are obviously very important. I was chatting to John beforehand. Clearly, we have to do blood tests. Liver disease, if you go to a heart clinic, blood tests offer very little. But if you go to a kidney clinic or a liver clinic, blood tests are an important part of what we do. So we do have to get blood tests done. At the moment, obviously, we can do them in our clinic, or they can be done at GP surgeries. And we're finding that a lot of the GP surgeries have actually been quite helpful with that. So, but we know that for some people that's more difficult. And I think that's one thing that the system needs to work through. The issues about general practice and whether people can get to see their GPs are well trailed. I won't go into that here, but we are certainly seeing a fair amount of pressure to do things that because GPs aren't able to or won't. So we just need to keep an eye on that. But blood tests being done. I have to say, for our trial work, we're moving to nurses going to people's houses to do blood tests, and that really is convenient for people. And I think that may be a future direction. So the ability to do online care and collect information at home is part of a move to the future. And we are very live to the fact that we do see people from Barrow-in-Furness, and a trip from Barrow-in-Furness to Newcastle and back in the day to have a 10-minute consultation may not look and feel like a particularly great use of people's time. My own observation about phone clinics is that they work quite well if it's me phoning up people who know me and it's Jess phoning up people who know Jess. That works really well. Some of our registrars find it more difficult, so they're less comfortable in the talking to people stakes. People will be familiar with that from clinics, so some people seem more comfortable talking. I don't think I've ever had any problem rabbiting away. Everyone knows that. So I think more experienced clinicians find that easier because we're used to striking up conversations with patients. So we are going to have to look at how we train young doctors to do that. And I do think it's not ideal for new patients. We have to build relationships. So there's a couple of ladies who for years I've managed at a distance, largely because they come a long, long way and have jobs where it's very difficult for them to get away without losing money. And we've always done that. And the joke between us is that the rest of the world is catching up with something that they have found phenomenally convenient for them. GPs do the bloods come through to us. We do a phone consultation, letter goes back to the GP, everyone's happy. But I think for new patients, we will need to try and see them because I think it is very difficult to get. A lot of what we do is done by feel. People often ask me why, when we're seeing people face to face, do I come out to the waiting room and walk in with people? I'm watching, I'm listening, I'm seeing all the way through. So every bit of the interaction gives us information. And for people I know, I can tell. I can sense what's going on in people, before we even start talking because of body language, things like that. So those things are the soft skills of medicine, together with a human, interface side. It's easier if people know you. It's more difficult if people don't. So I think we are hoping to move back to normal. The liver service is very busy at the moment for reasons that I don't think any of you will be surprised at. So for a long period of time in early lockdown, it was easier to get alcohol delivered than it was food. And so for a part of the liver community, that's been very challenging. So we are seeing a lot of problems with alcohol-related liver disease. And I personally, this is a personal view, I think that there has been a real failure to understand the broad impacts of the things that are going on people's lives. So, as I said, COVID is currently the 19th commonest cause of death. Liver disease is much commoner, and we are in danger of losing that. So we are seeing levels of liver disease that I haven't seen for a long time. And I think that's made worse by COVID, and the care has been an issue with it all. And I think there is, for me, there is a need to rebalance all of that. But everyone in the Freeman is working flat out, you know, seeing people and looking after them. My main worry, I have to say, is in less liver-focused centres. And I think this region is very well organised in general, has been around COVID. There will be exceptions to that, but I worry about some other parts of the country and the level of service that people are getting. So that's where we're up to. Now, immunosuppression and vaccination. So it would be impossible to have one of these fireside chats. I'll have to have a fake fire for next time. The vaccination inevitably is a topic on people's minds, and also the impacts of COVID on vaccination on liver disease, safety of it, safety in general, impacts of immunosuppression on COVID and liver disease. So the first thing to say is that when I teach the medical students, I make the point that there are two health interventions that have fundamentally changed the safety of our population in the last 200 years. And those are clean drinking water and vaccination. So actually, it's not antibiotics. If you look at the risk of death in our population, the two big differences were safe water and vaccination. And we sometimes forget that. And we're all, you know, a number of the people on this call are of an age. We've all had our smallpox vaccination. We've all had our BCG for TB. And I think when I started in medicine, I'm here at the old Newcastle General site today. We're all working from home at the university, and what I've done is I've managed to turn my home into something that looks like a university office. But I'm obviously not in my university office because I'm not allowed to be here. But it just looks like it was really difficult to get a authentic university-looking filing cabinet. But I'm not at work, obviously. So I'm here on the old general site. When I started here as a junior doctor in 1988, we still had iron lungs on the ward for people with the after effects of polio. And many people on this call remember the iron lung, where people were literally encased in a machine that would breathe for them. Now, I tell that to young doctors today, and they think it's something out of the 19th century, but no, it was there, you know, we were still doing that. And why we don't do that anymore is vaccination, okay? Bit of vaccination, bit of clean water. So polio has disappeared in our population, largely because drinking water is cleaner, but then absolutely because of vaccination. So we need to remember that vaccination has been something that has literally changed the lives of people. Vaccination is one of those strange things that is unlike cholesterol lowering treatment and, you know, antibiotics or, you know, hip replacements. None of those are politicized, whereas vaccines are politicized. And I'm not sure I quite understand it. And one of the issues with vaccination is that there are two beneficiaries from it. One is you as an individual get the benefit that you get, but the other is the societal benefit by having a large number in the population vaccinated, okay? And this is where the odd politics can all come into it, because why should I, as an individual, have something done to me in order to protect other people in society? And we cope with that. It's against the law to walk into a theatre and shout fire because you feel like it, even though it erodes your free speech. So we do put constraints on individuals to protect the whole. And of course, in our world, in liver, transplantation revolves around the altruistic acts of people whose death goes to save the life of somebody else. So this idea that we are altruistic is something that we have and we feel about. So the whole politicization of vaccination perhaps forgets really important messages, you know, in our history. That's not a political statement. It's just that we forget, you know, forget our history at our peril. What do I think about COVID vaccines? So I think they are far more effective than I guessed they would be. So I was worried about their lack of effectiveness because of the ability of the virus to change. And I think I'm very, very surprised at how effective they are, but very pleasantly surprised. And I think that they are extraordinarily safe, although they are not 100% safe. And that, I'm afraid, is a reality. So I think the clotting side effects with the clotting side effects of the AstraZeneca vaccine are real. They affect a small group of people, but they can be very negative when they happen. So I think that's real. I think there is less of that with other types of vaccines. So I think the Pfizer vaccine probably has a lesser side effect profile, but both of those cause vanishingly small numbers of side effects. I, unlike everybody else of this call, have seen young people dying of COVID, okay? And it is not a very nice thing to see, and it is not a very nice thing to have to manage people. And I'll leave it at that. And I think anybody who doubts whether COVID vaccination is a wise thing to do should just, you know, I'm happy to explain what it looks like, but I don't want to have to. But I think to get those things in balance, and the risks of COVID, particularly in, you know, younger people where it's a devastating illness, I think it's an easy balance for me to make. Okay, an easy balance for me to make. I personally think children is a different matter, and I think that is a debate that we need to have. And generally speaking, I've been very saddened by the level and quality of debate about many aspects of COVID. And I think we as a society should have talked about some things more rather than just having entrenched positions on Twitter, which I think, and that is it is a frustrated observation on the state of our society, as you will detect. None of my comments have a political element to them at all. They are observations of a 32-year clinical veteran in the NHS about things we could do better. So for me, the balance is easy, and vaccination is the right thing to do. Now, vaccinations are safe in everybody who is immunocompromised. Okay, so that's important to say. These are not live attenuated vaccines. So people are used to, if they're on sort of immunosuppression with transplant or AIH or something like that, are used to the concept that you shouldn't have certain types of vaccines. You're fine having synthetic vaccines, and you are fine, not fine having live vaccines. They tend to be the older types of things. Now, none of the vaccines that are used in COVID are live vaccines that can replicate. So there is no concern being immunosuppressed having those types of vaccinations. That's very important to say. Do they work as well in people who are on steroids or who are on other types of immunosuppressants? And the answer is, I'm not sure we know. So the problem is vaccines work in lots of different ways through different components of the immune system. And those different components of the immune system are measurable to a greater or lesser degree and are stimulated to a greater or lesser degree by different vaccinations. So measuring just one bit of the immune system gives you an incomplete picture, okay? Now we know this from hepatitis B, where with hepatitis B vaccination, some people will produce an antibody response to it and some people won't. But all people who are vaccinated for hepatitis B are protected against hepatitis B, which is at the end of the day, the only thing that matters. Now, I know that a lot of people are worried post-transplant things about not producing an antibody response following the COVID vaccination. But remember, it is almost certainly not the antibody response that is protective against COVID. So the answer at the moment is we don't know. It would be helpful to know. I'm not sure we ever will know, because all we can do is measure components of the immune system, but we are truthfully can't measure all components of it. Is any one of the vaccines preferable in people who are immunosuppressed? I don't think we know. At the moment, we don't have a choice as to which vaccine we get. As a clinician, if I'd had a transplant, which would I prefer to have? Probably the Pfizer vaccine, because its synthetic nature allows you to be a little bit more crafted in terms of the response that you get to it. But I don't think there is any way that any of us can influence what they have. And I think the advantage is to be vaccinated versus to not be vaccinated. So I think it's slightly an open question. Does that mean people should shield if they've had a liver transplant? No is the answer. I don't think they should. They should be vaccinated. There should be an open question, but the evidence that any form of shielding or wearing masks or wearing visors or anything actually works is very limited indeed, as we can see, because the cases are going up very rapidly at the moment, despite people doing all of those things. So, and there are plenty of people who I've met who are totally frustrated because they shielded all the way through and yet still caught COVID. So I'm afraid that it is impossible to 100% protect yourself. What about what would I do? What would I do? You know, I am unfortunately not in my 30s anymore. I know that's a surprise to many of you because of my youthful good looks. Also not a surprise given that I've been in the NHS for 32 years, so I had to have started very young. So I'm afraid I'm in a risk category for COVID. I'm an overweight man in his 50s. So we're all, you know, we've all, you know, drunk from the Kool-Aid, if you like. So what do? I was vaccinated as soon as I possibly could be. I avoid those sorts of situations where there are very large numbers of people that are uncontrolled. I think it's slightly strange that kids can't go to school, but 90,000 people can break into Wembley and throw beer over each other. I'm not sure I understand all of that. I wouldn't have gone to Wembley to watch football, would go for a walk in the park. I would sit outside a pub and or sit outside a restaurant. I would sit inside a big restaurant if there's plenty of space around. I think it's just common sense. And I think that's what we all collectively need. And I think people have got very entrenched in, we must control everything or we must control nothing. And the answer is exactly the same as I give to people after a transplant in terms of infectious disease in general. Be sensible about it. Don't bounce a baby on your lap that's got a streaming viral infection. But on the other hand, don't not go to the cinema in case somebody in the cinema has an infectious disease. So we all have to live our life, but it's just an element of common sense. Remember, in the bigger scheme of things, we don't immunosuppress anybody with liver disease to a very significant degree. So the levels of immunosuppression that are used in, say, heart or lung transplant are vastly higher than they are in PBC, you know, in AIH or post-liver transplant. So everybody with liver disease, either transplanted or not transplanted, has a lower level of immunosuppression than people sometimes think. And that does mean that you can cope with these infections better than people sometimes think. And remember that infectious disease actually is very rare as a problem post-liver transplant or in AIH. So everyone worries about it, but in reality, people have no more infectious disease problems than anybody else in society. And that's because we tailor and adjust the immunosuppression. So I don't think there is a particular concern with immunosuppression. So I can't be specific all of that, and there will be exceptions to everything. But my gut feeling in all of this is that I understand why people are worried, but I think there is less reason to be worried than people perhaps think. And I think common sense wraps it most of all up. But please, please, please do be be vaccinated. Amongst it all, this is a very exciting time in terms of our research, and I've just written down about a number of sort of trials in particular. So I think one of the things I look back on with enormous pride is the fact that we do have new drugs being trialed and coming into clinical practice in PBC and IH, and I think that's been a major achievement for everybody. And the really big headline news is we've launched the trial called OAKS. Very recently, we've enrolled our first person, and this is to use obeticholic acid specifically to treat the symptoms of PBC. So in particular, the brain fog of PBC. So this is the first ever trial targeting that. And this is not using obeticholic acid in people who fail to respond to other therapies. It is to target the symptoms. So if you are somebody who experiences brain fog, then do think about that. Kath Houghton, who many of you know, is the nurse in charge of the trial, and Aaron Wetton, who's one of the fellows working with us, are lovely, and they are sorting out recruitment into that. And that's a really big deal. That's a really important trial. The other trials that are going on are around ever better drugs to treat PBC patients who don't respond to therapy. So there are a number of trials coming along, and there are a couple of trials in the area of itch, which again is turning out to be a very exciting area. And there is one particular drug coming, made by a company called Escient, E-S-C-I-E-N-T, Escient, which to me looks like the best candidate we've ever seen to treat itch. Okay, so if you get offered that one or somebody mentions that one to you, I would seriously think about that. This is a drug which we think blocks the actual nerve transmission of itch at its origin. So it switches off itch in the signaling pathway that makes your nervous system recognize it. So it doesn't take away the irritation, it doesn't take away anything, but it stops your brain recognizing it, which is all you need. So that's very exciting. And then the other thing that's very, very exciting, I remember being asked in many of these calls, why do we not do things in autoimmune hepatitis? And the answer is we have the first trial in autoimmune hepatitis in many, many decades, called the AMBER trial, which is a really interesting one. Now, I can tell you it's quite a tricky one in terms of whether people are eligible for it with autoimmune hepatitis. But I can tell you from having seen the first cut of the data, it looks like it has an extraordinary effect in autoimmune hepatitis in switching the disease off. So it does look like it's a very exciting thing. And then the final thing I was going to say before I stop wittering is, in general, there is a change in liver disease, which I think is incredibly important. And that is a movement to what I call earlier, better treatment. To diagnose it earlier, prevent it if we can, where it is developing, diagnose it early, and use treatments to stop it in its tracks. Don't wait to fail with therapies. Don't wait to see what happens to people. Don't wait for people to develop cirrhosis and then do endoscopies and things. Treat this disease, and if we can't cure it, to fully control it. So the future of trials in my area is going to be about what we call disease modification, where we diagnose people at the beginning, we assess the risk they run at the beginning, and we then target therapy at the beginning to reverse that in its tracks. And the analogy I always use is a boulder rolling down a mountain. If a boulder is rolling down the side of a mountain, it's far easier to stop it high up in the mountains when it's rolling slowly than it is lower down the mountain when it has gained a huge amount of momentum. So the research programs have been challenged by COVID. Of course they have been, because people were very naturally not keen to come into hospital, and there's been a huge priority, correctly around COVID trials, but all our trials are now back up and running. And I think we are all making the point that we need to remember that there are lots and lots of health problems that people have, and that it's very, very important that we look after everybody in society, not just those people who have one particular type of disease. So balance in everything that we do. So I hope that's been vaguely interesting. Those are the things that people ask me about. I've tried to cover lots of things, give my personal opinion on various different things, but I hope that you find it mostly reassuring, and the things that are less reassuring are ones where we at the moment don't know. But to me, we are, with the caveat, it's really depressing, we're still talking about it 18 months down the line. With that one caveat, I think with COVID, we've ended up in a far better position than we could have been. So hopefully we will progressively start to get back to normal fairly soon. So John, I'll stop at that point and take any questions.
Yeah, that's good. Well, I'll start before anyone else,
things that
if you like.
Disagree with.
You said that there weren't that many patients in hospital now, and what about the staff being on the sick with COVID?
So that's a really good point. That's a really good point. So the main pressure we have at the moment is on staff being forced to isolate. I think we have, I think most recent figures, we have something like 40 people who are COVID positive in the Newcastle hospitals. Remember, we have something like 2,000 beds. So that's 40 people out of 2,000 beds. Remember also, those include people who are incidentally positive for COVID. And this is where I think the figures could be more transparent, because having a swab that identifies COVID is not the same as having COVID disease. COVID disease is a lung disease associated perhaps with clotting abnormalities. Having a positive COVID swab is not the same. So, and we never get a breakdown in the UK of how many people in hospital actually have COVID illness and how many people are positive for a COVID swab. The reason is that people get colonized, in care homes and things like that. Just as a factoid, to say, to get this into perspective, about a third of the population, something like that, carry Meningococcus in their nose, okay? Meningococcus is the bacteria that causes meningitis, about a third. Meningococcus colonizes people, okay? Colonizes, students, colonizes people for whatever reason. The vast majority of those people never get meningitis, okay? So Meningococcus is only a problem when it gets from your nose into your bloodstream or from your nose into your brain. Then it's a real problem. It's a real problem. If, however, we did routine nose swabs for Meningococcus, we would be in the midst of a Meningococcus emergency at the moment, because a third of the whole population have it. But a third of the population have always had it. Just remember that. So we are, for the first time ever, lumping together people who are colonized with an infectious disease and people who have illness from that infectious disease. It's the first time we've ever done that. And that's one of the reasons why we get terribly scary figures. We've never done it for flu, never done it for Meningococcus. We don't do it for Staphylococcus. Remember, resistant, MRSA. Large numbers of people in the population are positive for swabs for MRSA. So we have taken a slightly different tack with all of this. So the problem is very large numbers of people are being pinged by the app. Kath Houghton does a fantastic job supporting our patients, as you all know. She is currently marooned in Jersey because she went to get a break with her husband and he was pinged by the app, and now neither of them can leave Jersey until they have negative tests. So she now can't, she is herself negative, but she's been in contact with somebody who's positive, although he's entirely well, and so she can't get involved in managing patients at all. And that is a recurrent problem. So there are vastly more staff off having been pinged than there are people who have COVID. And the vast majority of those staff members don't have COVID, okay? They don't have actually a positive swab at all. They've just been in contact with people. Remember, my wife pointed an anomaly out to me, which I think is very interesting. So for those of you who don't know, my wife is a consultant in intensive care in one of the hospitals in the region, not in Newcastle. And she has intubated 30+ people with COVID. So when I talk about COVID, I know nothing compared to what she knows, because she was on the front line, has been for the last 18 months, okay? She got pinged, not because she'd been intubating people with COVID, okay, but because she'd been within 2 meters of somebody outside the hospital who'd been within 2 meters of somebody else. So when people talk about exposure risk for healthcare staff, any exposure in the hospital is excluded. So throughout the entire thing, she's never isolated, having been in daily contact with people with definite COVID. But the moment she went near somebody who'd possibly been near somebody else, that was a risk and she had to self-isolate. If anybody can explain that, do explain it to me, because I can't explain that and the common sense behind it. Okay, so at the moment, I think what they need to do is to decide whether we believe tests or not, decide whether we believe whether contact tracing works or not, decide whether we believe whether vaccines work or not. And I think it's at the moment, become absurd because it's become absurd with the numbers of people having to isolate. And I think the app is just too sensitive to all of this. And I understand they're looking at it and they will turn down the sensitivity. Children, aren't they a joy? My boys have been experimenting with their, they came home with sacks full of lateral flow tests, and they've been experimenting with them, and they have confirmed that Coke does turn it positive, fruit juice does turn it positive. One of the reasons why very large numbers of children are being sent home is kids fancy stopping school early, and they've worked out how to make a test positive. And just remember, lateral flow tests have been removed in America by the FDA because they are completely inaccurate. So a lot of this is on the basis of flawed tests and a flawed app. Now, I'm all for protecting people, but we all saw the scenes in Heathrow where large numbers of people were congregating in a very small area to get through security because people were being sent home because of these. So risk, reducing one type of risk can be translated into another type of risk. So I think there is a problem with NHS staff. Not particularly, I don't think, in Newcastle. I mean, our unit has not really been affected at all. I'm not sure, we've not really had any problems, and certainly had no problems offering a service. But I think they do need to look at it because it feels a bit oversensitive to me.
Mm. That's interesting. The Gateshead Hospital, they have 174 staff members on the sick with COVID-related problems, but it's probably because they have to isolate. Yes. 21 people in the hospital with COVID and 4 people in ICU. Yes. They're all predominantly younger people. Yes. Yeah, but the staff are younger people as well, so they're kind of, because the staff are not in their 60s and 70s. No, and I think, I'm sorry to say, age is a factor in it, more than most diseases I've come across. Being a man is a risk factor for it, and being overweight is I'm sorry, John, but you and I have don't look at me. And I think that's where common sense comes into it. And I do think I think what we've done around the vaccination has been hugely successful. I do think that as a country, but I don't think we've necessarily maximised what we've got from that. I think we've ended up, I think we're stuck at the moment, to be honest, and I think we're in a bit of a pickle. Okay. We need to try and find a way out of it. Okay, I've got a couple of questions for you. The first one is Sheena. You were the first one. Sheena, can you unmute yourself? We're just waiting for Sheena to unmute. No.
Good.
There you go. Okay, Sheena, let's have your question.
Sorry.
Oh.
Can you hear me now?
Yes.
Can you hear me?
Yep. Yes.
No. Can you hear me?
Yes.
Right, it's very slow this today. Just an update. I worked at 9 Wells in Dundee, and we had 8 people in high dependency and 5 in critical care. And they're mostly young people. The staff, there's a lot of staff down with sickness as well, like down in Newcastle. But the doctor was predicting about 2 million people having COVID to the end of the summer, and by winter, 10 million. That's what they were saying. It's crazy, the numbers, if that's true.
Well, I think I'll let
And
Dave
expecting
answer that.
about 200 deaths a day.
Right. Oh,
Yeah, so I think
Now. Mm-hmm.
I think I can only really speak for, you know, our experience here, and you know, at the end of the day, I think Newcastle has something like 90 to 100 critical care beds, and fewer than 10% of those have a COVID patient in them. So, you know, each one of those, of course, is, you know, a sad story, but you know, critical care units are pretty much always full. So it is a component of what's going on. Now that is very different to early part of last year, which, so it is, and the dynamic is very different to then in terms of the numbers of patients and the speed at which it changed. So I think each of the waves has felt different to me as a clinician working in it. So the first wave was very scary, I'll be honest. The second wave was a slower burning version of that, although the numbers ended up very high. And the third one is a sort of odder one, because you're seeing much more in the way of sporadic cases, but on the background of a large number of positive tests. I don't know what the answer is. I think the answer, so the first thing to say is that a lot of what we hear is modelling, okay? Now we model in PBC, we model to understand what we don't understand. And when you create a model, you do what's called parameter. So modeling is a computer program that predicts what's going to happen based on assumptions that you make, okay? So, and the reason you do that is, so we do it to say, there's a trial in PBC takes 5 years to do, okay? And it's very difficult to do more than about 2 or 3 trials at once, because it's a rare disease. And so it's going to take us a long time to get all the answers. And actually, if there are 20 drugs that we could use in PBC, how do we pick the 3 to test? And how do we know they're the best ones to test? Okay, so we use modeling to test those ideas. So if we try and understand how the disease bits interact with each other, what a model does is say, if I sort of reduce the number of, if I halve somebody's alkaline phosphatase level with a drug, what would be the expected effect? Okay, and it allows us to predict different outcomes with different changes, and from that to work out what is the logical thing to change and what's not a logical thing to change. So one of my colleagues described it as pushing and pulling on a piece of string. So you've got a coiled up piece of string, one hand you're holding it, the other hand is attached to something. You're connected whether you push or pull it, but only one of those will move what's at the other end, okay? So that's why we model. Now in making a model, you make assumptions about things. So, you know, if you're going to do that in PBC, alkaline phosphatase blood tests, you predict what the effect of a drug might be, but you also predict what the effect of reduction in a blood test would be on the disease. Now that is an assumption, okay? And that assumption might be right or wrong. But when you put parameters into it, it is colored by your views of the disease, okay? So I'm not sure that alkaline phosphatase is a very useful test, so my assumptions would be to not put in too big an effect when you link alkaline phosphatase to a response. But if I believed completely that alkaline phosphatase was everything, I might put a different thing in. So we hear a lot of models. Those models have largely not been very accurate. They have tended to overpredict bad outcomes, and they tend to be parameterized in such a way. And just be aware that a model, that if you put in a number of assumptions about how bad COVID is and you run the model, and the model then tells you how bad COVID is, it simply reflects the assumptions you put in the first place. It doesn't, none of these things see the future. What they do is they they should allow you, what they should be being used to do is to compare the outcomes of treatment A versus treatment B, the effects of vaccinating. So a really good modeling question would have been, should we vaccinate everybody over a certain age with 2 doses? Should we vaccinate everybody with 1 dose above a certain age? So, you know, you've got choice A, which is to use 2 vaccines on each person, versus choice B, which is to double the number of people treated, but halve the number of vaccines. That's the sort of question that modeling can answer. What it can't do is see into the future as to what's going to happen. So, yeah, you know, you can take the graphs. If you go on to something like Worldometer, which presents the data around the world, you look at the number of cases in the UK, cases of positivity for the virus, remember, not cases of hospitalization, and you look at those numbers, you know that line's going up like that. So you know, you can extrapolate that wherever you want. At some point,
you're frozen. That's it.
Oh, am I back?
Yeah, you're back.
You can extend that as long as you want, and you can make whatever prediction you want based on that. So is COVID around? Yes. Is it affecting enormous numbers of people? No. Is it affecting some people? Yes. Is it a horrible illness still? Yes. See private comments about it's not a very pleasant illness at all. But I don't know what the answer is, because at the moment, as I said, it's the 19th commonest cause of death in this country, and we are in danger of increasing significantly deaths from other causes in order to protect against other things. And I'll just give you an example of a case I was involved with at the weekend, which is somebody who ended up coming to Newcastle from a very long way away, indeed, inappropriately, because the local hospital they should have gone to didn't have an ITU bed. Well, in fact, they didn't have an ITU bed, but they were keeping it in case they had a COVID patient, okay? So you had a real patient dying of a real illness who couldn't be managed in case a future unknown patient might need it. So we just need to take a big, deep breath and, you know, be prepared for as many eventualities as we can. But at the moment, we are in a hole and there is no easy way out of it. But we have to make sure, you know, we have to make sure that we don't neglect other things that are treatable. For those people who everything should go into COVID, my next door neighbour's daughter-in-law died in her 40s from cancer, from a diagnosable cancer elsewhere in the country because she couldn't get a GP appointment, okay? So, you know, 3 young children under the age of 8 without a mother, and I think that's a COVID death personally, but it will never appear in the figures. So as a doctor who does the best for everybody, that worries me a lot.
That's great, Dave. Is that okay, Sheena? Do you get your answer?
Well, I was just passing on my
Yes.
I was just passing on my numbers from Dundee here.
That's good. Well, you keep looking after 9 wells there. Okay, we've got Hillary has a question. You need to unmute yourselves. There you go.
Yes, I'm actually with Hillary Yates. You get David Yates as well. It's
Hi, David.
Buy one, get one free.
The questions I've got are, I first of all like to thank David Jones very much indeed for that presentation. Although personal, it had some very interesting information in it. I'm an 80-year-old heart transplant patient of 33 years. I am regarded as in the clinically extremely vulnerable. The advice we have on shielding is, shall we say, make up your own mind. We understand that antibodies in the vaccine is a meaningless equation.
Yes.
Though I understand that Papworth are offering it to their heart transplant patients in Cambridge, but the Newcastle Transplant Clinic here are not offering that.
What, to measure antibody levels?
Yes.
Yeah.
I had a review this morning in the Freeman, and I was told that in no uncertain terms that the efficacy of the vaccine was so problematic in my particular instance, shall we say, that I should actually shield. I mean, I mean, that is obviously the clinical advice that I have received. But I'd be very interested to know your reaction to the comment on antibodies, whether they are relevant or not relevant. I appreciate that T cells become more relevant, et cetera, et cetera. And in your experience in terms of heart transplant patients, immunologically at risk,
Okay.
where do you go?
So I know very little about heart transplant, so forgive me with that. So I think, good question. And there is what we know and what we don't know, okay? And one of the things is the difference between fact, evidence and opinions. And we need to be just aware what's evidence and what's an opinion, okay? And opinions can be informed or they can be ill-informed, but that they are opinions. So that the data, so it's what we know and what we don't know. So the first thing to say is that antibody data cuts differently in different directions. So the presence for antibody does indicate that somebody has had an immune response to the vaccine. The absence of antibody does not, however, indicate that somebody hasn't, if you know what I mean. So it has what we would call positive predictive value, but not negative predictive value. So that's the first thing to say. We don't tend to measure antibodies, largely because it's difficult to know how to use the information. I don't know what to do with that information other than to use it to be reassuring to somebody who had the antibodies. Okay, so that's the first thing I would say. And I don't know what their local policy is. That's the first thing. The second thing is my comments about transplant were around liver transplant. And as you will be aware, heart transplant patients tend to have higher levels of immunosuppression to do with the way the immune system works in liver transplant and heart transplant. So the heart is more immunogenic than the liver tends to be. So, so in that sense, you must take that context. So without going into individual levels of immunosuppression, somebody who's had a heart transplant is going to be towards the much more immunosuppressed end of the spectrum. What I would say in terms of data, I don't know what the data is on heart transplant and COVID risk, but I would suspect there may not be very much. So one of the dangers is you are getting opinion rather than data-driven things. So if there is a study, that has looked at heart transplant COVID risk, I've not seen it, nor particularly would I have done. And so heart transplant, COVID and vaccination. But remember that the internet is a great democratizing tool, okay? Is a great democratizing tool. So there is a website called PubMed, P-U-B-M-E-D, which is the US government. It is the best resource for searching literature. It's a search engine, PubMed. It's the one we routinely use. You can summon it on your phone, on your computer, just put PubMed into Google and it will come up. And you can put in heart transplant COVID vaccine, okay? And you can find out, you know, and you will see what people have written on it. And actually, I'm absolutely all in favor of democratization of research. And you can do that right now, okay? Now, it's the scientific search engine, and where you'll be less comfortable will be in terms of working out what is good quality evidence versus what is lower quality evidence. In general, you want to look at studies that have looked at lots of people. So the larger the study, the more accurate it is, but it's out there. Don't do it in Google. I know this will shock everybody, but There's a lot of rubbish on the internet. That's a surprise. But you can put anything you want on the internet, but PubMed is peer-reviewed papers. And so it is the one we do to search for evidence. So if I am looking for evidence about something, I would go into PubMed, and I just recommend people to do it. And it will give you the abstract of the paper, which is the summary, and it will, look at the beginning of that and the end of that, and it will tell you. So I don't know if anybody's done that. I will do it straight after this call, just because you've asked the question, and I'll send the answer to John. But that is a hepatologist's view of the heart transplant literature, which you can take with probably not a pinch of salt, because I suspect you don't take much, but a pinch of low sodium salt. So I would guess that we don't know. I would guess that after a heart transplant, you're at the higher end of risk because of the level of immunosuppression. And the answer about the level of shielding is whatever is compatible with a sensible lifestyle and a sensible quality of life. So for me, it's about common sense, as I said, rather than anything else. And I know plenty of people who literally shut themselves off the world for 6 months and then went out and got COVID. And I think that's the problem, is that there is a time limit for all of these things actually to happen. So I think avoid crowded. If it were me, I would avoid crowded places. I would absolutely avoid anybody who had symptoms. I would be outdoors as much as you can. I think all of those things have made a difference. But I have to say, you look remarkably well at 80. That is a big factor in all of this. And I have to say, one thing I will say is all the evidence is that immunosuppression is not the problem that people were worried it might be. That's not to say it's not a problem, but have we seen massive problems with our autoimmune hepatitis patients who are on immunosuppression compared to our PBC patients who aren't, and their family members who aren't? And the answer is we haven't. So there does not appear to be a major issue out there. There may well be a minor issue. In those situations, it's really, really difficult, okay? It's really, really difficult. And I'll just tell you a little story, which is about a colleague of mine who's just had a big operation because she was found to have a mass, okay? And she was terrified that it was cancer, okay? And this has got nothing to do with the liver at all. It's just a colleague and a friend, right? Who I've worked with for years and years and years. And nobody would tell her what they thought was going on. And everyone would tell her about what cancer services were available. And, if it is cancer, we can do this, that, and the other, right? And she just wanted to know, what's the likelihood? I'm a big grown up, I'm a big adult, I'm going for a big operation regardless. I need to just, for my own head, is it a 1% chance, or is it a 20% chance? Is it a 50% chance? And nobody will be honest with me, okay? And so I went through the whole story. It's not in my area. And I said 2 things. One is, I am not an expert in this at all, but I've been doing this for 30 years. 2, I think I've got a reasonable level of common sense, and I've kind of, looked at the evidence over things. And 3, when I hear all of that, this does not sound like cancer to me, okay? I can't tell you that because I don't know. Nobody knows, but my gut feeling after all these years is it probably isn't cancer. You need to have the operation, you need to have it out, you need to have all of that done. You need to be prepared for it. But do you know what? I don't think it's cancer. And she had the operation yesterday and it wasn't cancer, okay? And she texted me and said, thank you, because the last 2 weeks I've been able to stay sane because I listened to what you said and I knew you didn't know for sure, but it's your gut feeling. And I think it's everyone else, her clinicians all said exactly the correct thing, which is we cannot exclude cancers, therefore we need to do all of these things, which is exactly correct. And what your clinicians are saying is that we cannot.
We've lost you, Dave. Can you hear me, everyone?
Yes.
Yeah, we've lost Dave.
it's one where you have to take the balance with it. But I will look on that. I will do search on the literature.
We lost you for a minute there, Dave.
Okay, sorry.
Thank you very much. Thank you.
But remember, this is, you know, I want to help give people honest advice about where we are with it all.
Yeah.
Okay.
And I think
I'd like to thank you very much for that. I mean, you're actually talking the same language that I actually use.
yes.
I tend to feel that the only way you can look at these things is a bit like the Butch Cassidy Sundown situation. You know, if you jump into the river, you can't swim. The fall will probably kill you.
Just generally speaking, okay, just generally speaking, it's an observation. The people who got COVID in my family were the fit ones and who were fine with it. The people in my family that everyone was worried about didn't get COVID and have pretty much gone back to normal. So if I look at all aspects of my life, COVID has been entirely random in terms of the people that have got it. And I've not known anybody personally who's had bad COVID. So I think it in a sense, everyone thinks it has this utterly predictable effect in entirely predictable people. But in my experience, it's been very unpredictable. And as I say, you know, I think it's about, but it's also, you know, it's the thing that we talk about in the clinic all the time about risk. And I'm not going to do this because of the risk. And I always say to people, you know, you come to the clinic and decided not to have a treatment, okay, because of the risks to the treatment, but you took a risk coming to the clinic because you could have had a car accident. So logically, you should have stayed at home. But if you stayed at home, you could have run the risk of the roof falling in or getting a DVT. So risk, nothing we do in life is risk-free. And it is understanding the totality of risk and also understanding what is to an individual an acceptable and reasonable risk, and remembering that that is an entirely personal opinion. And so it goes back to this, there's this thing called cognitive dissonance. So it's why do smokers smoke? And how many smokers don't know smoking is bad for them? And the answer is none. All smokers know smoking is bad for them. But what they do is choose not to act on that. Now, that's what's called cognitive dissonance. That is somebody doing something which is not logical, but understandable, if you know. Now, in a way, I can't understand that, but I can understand why somebody would take that view. And I think it's sometimes doctors struggle with people not making their own decisions. And we see a little bit of this coming out with COVID, which is, well, we've told you what to do, why aren't you doing it? Well, we've told smokers not to smoke, and yet some of them still do. And I think it's a much more complicated thing. And I think it's ultimately what risk you as an individual, and anyone as an individual, takes. And I take this to the absolute intellectual level, talking about liver transplant, when I say it's like playing pontoon. This is very intellectual. It's like playing pontoon. Some people twist on 16 and some people stick. Okay, and there is no evidence which of those to do, and therefore people make their own decisions. So it's not logical sticking on 12. It's not logical twisting on 20. But sometimes in life it's 16, and you have to make your own decision, and one that you're comfortable with. I will, John, when I go, search heart transplant and liver transplant and COVID. Okay,
we've got two more people. We're going to try Yvonne first, she had her hand up first, and then Joan. But Yvonne, are you going to try and see if we can hear you?
Yes, I don't know whether David is picking up my message in the chat room.
No, I think, John, are you picking up the chat question?
Okay.
Yes, I've got the chat, yes.
Yeah, okay.
It's what about, can you hear me, John? Can you hear me?
Yes, you're fine, it's fine.
Yeah. Right, okay, thank you, John. Thank you, David. My question's about allergies and COVID vaccines.
Yeah.
The nut allergies, for instance, are an anti-inflammatory allergy. So would there be a best option of a particular vaccine? And is there an anti-inflammatory ingredient in the vaccine that you would know of, David, that could cause a problem for someone with a anti-inflammatory allergy, for instance?
So no, I wouldn't be concerned about that. So the just so people know, the AstraZeneca vaccine is a engineered virus that cannot replicate and which has been engineered to express the protein. So it has some viral proteins linked to it, okay? And the Pfizer vaccine is totally synthetic. So it consists essentially of a lipid surface, a fat surface, and then it has what's called mRNA. It has genetic code for the protein in it. So again, the experience of everybody, and this is evidence based on now literally millions of people with the vaccines, is that allergy risk is very, very low indeed. And so it has not been a problem at all, although it was a caution inevitably when you started with the vaccines, when you know, when they are totally new. So vaccine use in people with allergies and allergies arising after the vaccines have been vanishingly uncommon. Okay, of the two, and again, that the caveat is that I'm not aware of anybody who's ever been offered the choice. Of the two, the Pfizer one has less components to it, if you like. So it's proteins that you mount allergies to. It's a protein that does it, or a drug bound to a protein in the case of, say, an anti-inflammatory. So the Pfizer vaccine, because it's basically a lipid layer and then some RNA, it's got nothing you can mount an allergy to, in simple terms. So of the two, it's probably the safe one. And I think most centres, I think it's also slightly dependent on where you go and get the vaccination as to what's available, but most, the hospital systems will tend to use, if in doubt, use the Pfizer one, because it's probably the cleaner one and it's probably slightly more effective one. And so I think if I had an ability to, nobody listens to me, but if I had the ability to persuade people, I would take anybody with a chronic illness and give them the Pfizer vaccine. And it's also going to be the one that's going to be engineered much easier for variants because of the way it's built. Basically, you can change the code inside it very easily. So when people do an annual flu vaccine, it's literally based on mixing a soup of different flu viruses. So it's a very inexact science. So basically, they cook up a recipe. Whereas with the Pfizer vaccine, it will be scientific. You can actually clip out the sequence where the virus has changed and clip in a replacement. So it's exactly the same vaccine, but the specificity changes. So it is a neater technical solution, I have to say. And that is the major advance with it all. So no particular concern, but if given a free choice, personally, I'd have the Pfizer one in that situation.
So thank you, David. But so if you have the AstraZeneca one first,
yeah,
would it be feasible to ask for the Pfizer one afterwards?
Yes. There's a trial of that going on at the moment, and I think the evidence is that they are cross-compatible, absolutely. So that if you have one, then the second one works just as well. And there are some very tedious immunological reasons why that may in fact be more effective. But I don't think that's opinion, not fact. Fact is that if you split the two, they are effective, and fact is that they are safe in terms of allergy. Opinion, it may be better to split the two.
Good, that's excellent. Well, I've got that. Is that okay, Yvonne? I know that Yvonne's question's based on the fact that you know someone who had the vaccine and came out in an allergy rash. Is that right?
No, it wasn't an allergy rash. He went to A&E.
Oh yes, he had an allergic reaction. Sorry, yes.
Yeah. It was an A&E job. Yes, it was a casual job, John. Yeah.
Okay, I've got Liz's hand up, but Joan's first. Unless Liz is do you want to be first, Liz? No. Okay, Joan, you need to unmute. That's it.
As if I didn't know.
Well,
as ever, David, thanks very much for a very informative
it's
entertaining.
Sorry, it's £10 to charity if you talk with the mute on. So you have to pay yourself £10. You're the first person from a charity who's had to pay the charity fee.
All right.
I'll take it from my pay rise.
Yeah.
Anyway, Yes, thanks very much for a really informative and entertaining talk. My question relates to the reference that you made to the AstraZeneca vaccine and clotting.
Mhm.
If you have a history of DVTs, would it be reasonable to assume you shouldn't have the AstraZeneca?
I don't know what policy is on that, so I don't know whether they're doing that. I'm not closely involved enough with the vaccination program. The risk with clotting with it appears to be of unusual clot, so it does not appear to be making DVTs worse. It appears to be two things. People get what's called sagittal sinus thrombosis, where the vein draining out of your brain blocks off. That's the one that kills people. And then the other one is we see in situ thrombosis in the lungs in people with bad lung disease. So those are both very unusual clots, okay? So this isn't an increased rate of normal clots, it's unusual clots. Another thing that people worry about is low platelet count. I get asked that all the time. So the clotting is said to happen, is said to occur with low platelet counts. But just to say, a lot of people with liver disease have low platelet counts. Low platelet counts do not predispose to the clot. If you're developing the clot, you develop a new low platelet count. So just to say, if you've got a low platelet count with liver disease, that's nothing to worry about. That it's only if it happens after the vaccine. So we're talking about 30 or 40 people in the UK having that, but those are pretty devastating complications. I think, to be honest, and again, this is an opinion rather than anything else, I think the AstraZeneca vaccine will fade away, and I think we'll move towards the more synthetic ones, of which the Pfizer is one, but there are others, coming along. And I think any vaccine was better than no vaccine, but there is now starting to become a hierarchy. So the Sinopharm, the Chinese one, is by some distance the lowest effectiveness one, and that's not used in the UK at all. There was one done by Johnson & Johnson, which seemed to have the advantage that it was a single dose, but has the disadvantage that it's not that effective, and it also probably causes the clots. So I think it's going to be the Pfizer ones and ones like that. For me, if I were prescribing it and somebody had a clotting history, if it was a proper clotting history, I would use the Pfizer, but that's a soft bit of advice. I think if you had a complex clotting history, if you had Budd-Chiari or ischemic bowel or something like that, which is the more problematic ones, or a pulmonary embolus, then I would be pretty clear that. And what you're trying to do, I mean, again, I can't say what they do on the ground, I'm not that closely connected to it, but what I'm trying to do in life is to avoid things where somebody can come along and ask a really simple question: why didn't you do something else? And the AstraZeneca one's associated with clotting, and somebody's got a clotting history, why don't you use a different vaccine? It's a really good question, and for me, therefore, you would avoid it. But it is part of the difficulty is how those are provided. And as people will know, it is much more difficult to store and distribute the Pfizer vaccine because it's got to be frozen and deep freezed in very low temperatures, whereas the AstraZeneca one, and I think at the end of the day, getting the AstraZeneca one is far more safe and effective than not getting the Pfizer one, if you know what I mean. So, but I think over this time next year, I think the AstraZeneca one will have disappeared.
Thank you.
Excellent. Liz, you had your hand up.
Yeah.
There you are.
Well, just to say thank you very much. I think the talk has been fascinating and given you a little bit of confidence about moving out now with the COVID. And Joan, your hair's lovely. But my question to Prof Jones is about this Oaks trial.
Yeah.
Yeah, with the obeticholic acid.
Yes.
In previous talks that you've given,
Yes.
you've also said that it causes itch.
Yes.
I very rarely get the itch.
Yeah.
And I would quite like to try a trial that might help my memory. Mm-hmm. But to get the itch, my mother had the itch. Yes. Incredible. And that, when you've talked about it, I've thought, really.
You don't fancy that? Yeah. Okay. Guy, we're talking about PBC. Brilliant. Okay. Trial. So the important thing about obeticholic acid is that the itch is a very manageable issue. Okay. So most people don't get it, and where people do get it, with the experience we've got. So now obeticholic acid is in widespread clinical use for people who don't respond to urso. Okay. So it's used, but the average time after the diagnosis of PBC is about 10 years. So we're giving it, you know, late, and we're not targeting it at symptoms or not looking at the response. So this is to look at symptoms.
Yeah.
So what we find, so we've now in the UK treated 200-300 people, something like that, with obeticholic acid. And actually itch in practice has been a minimal problem. So it's funny being aware of it, warning people, and then putting in strategies to control it, all of which are part of the trial, means that it is not the issue that everyone worried it would be. So yeah. I think I think if somebody's got really bad itch, then it's something that's, you know, worth thinking about. But I think if people are worried about itch rather than having it, then there are absolutely effective ways of mitigating it. So I have to say, I have few, if any, problems with itch these days. So I wouldn't use that as a reason not to find, you know, trials are for some people, not for other people, you know, the score, you know, lots of criteria and things. But where we are today in 2021, itch is not the problem everyone thought it was going to be. However, you need to think about it in everybody. So we in UK PBC, our national thing, we wrote some guidance, put it on the website, which is used around the world, which is how to approach itch with obeticholic acid. And the answer is to get your retaliation in first. So start people on a bit of treatment to control it, and then you wean that treatment out once on obeticholic acid. So there are really good strategies. So if you are interested in it, then absolutely think about it, and I wouldn't be worried about itch.
Right. Yeah. Thank you.
Yeah, we can put people in touch with Kath Horton.
Yes,
and that's, you know, if anyone's interested.
Sorry,
That's
a general observation about obeticholic acid. I think the concern about itch with it for ordinary use is also the same. It is, we think about it in everybody, we talk about it in everybody, but the having problems with it is incredibly unusual.
Excellent.
Amber.
Any more questions for Prof Jones?
The AMBER trial. There have been
the AMBER trial, oh yes.
The AMBER trial. So the AMBER trial is AMBER. It is a Novartis trial, Novartis, the drug company, and it's in autoimmune hepatitis. And if anybody is interested in it, I can send information to them. It's essentially using a biological, so it's using the new generation of treatments that have been so effective in arthritis and inflammatory bowel disease. And it's a really clever antibody. So AMBER, that's just they all have these clever names, trials. And so it's, so if anybody's interested, like a lot of these trials, it has quite specific criteria. So don't be disappointed if people aren't eligible for it. But it looks really interesting. For what it's worth, the goal in autoimmune hepatitis is to move away from steroid therapy, okay? So the thing we need to do with autoimmune hepatitis is in general, get treatment better, but absolutely get treatment better whilst not resorting all the time to steroids. And I doubt there is anybody here who would object to that.
Excellent, excellent. Now, Marion's got a hand up. Are you there, Marion?
Yes, I'm here.
You've got a question for David.
Yes, I've got very little battery left, so I'll be quick. I was called by Kat Houghton about the Oaks trial, and we discussed that I'm on urso and I'm also on bezafibrate, and she said that she thought that I was excluded from the trial because of the bezafibrate.
Okay, yes, I'm laughing because that's a trap we've encountered. Okay, so as you know, trials take an awfully long time to develop. So this trial has been, you know, take a length of time, then double it, and then double it again. It's usually a useful rule of thumb. So in the time where we've been developing this trial, a lot of people ended up being started on bezafibrate, which is a different drug to obeticholic acid. We use it in PBC. There's no real evidence it works for symptoms, but it is useful in people with higher risk disease. So the reason we excluded it in the trial protocol was because because we couldn't prove that it didn't have any effect on people's symptoms. But there is a large group of people who would otherwise be eligible for the trial and be interested in it, and who are on bezafibrate and who still have the symptoms. So what we're going to do is amend the trial protocol to allow combination therapy. Now, just to complicate things, there is already a trial of obeticholic acid, urso, and bezafibrate. The combination appears very effective for PBC, so there's no problem using the combination. It is under evaluation, is used in a number of people. So the message, we are talking about that. The message that will come out from Kath will be to say to people, give us some time. The trial runs for another 2.5 years, and so we will have an amendment. It will take a few months, but the idea is to amend the protocol so that we can give the combination.
I was also because the brain fog or whatever the cognitive dysfunction is my worst symptom,
Yes.
and I'm actually willing to go off bezafibrate.
Yes. Well,
to be able to take part in the trial. Yes,
and that's the other option. I think that's the other option, and obviously, as you know, Oaks is a short-term trial. Okay. So we are aware that it's that we're looking at it's only months, not years. And so where people are on bezafibrate or any other drug and choose to come off it, then it's for a finite number of months. Now, there is a placebo arm, so there is a possibility that you replace bezafibrate with a placebo, but at the end of the trial period, then people there is the option to go into the NHS system and go back onto whatever drug. So that is a very reasonable thing to do. That is a very reasonable thing to do. Can I suggest, do you want to get, are you in touch with Kath still?
Yes, well, we spoke last about 6 weeks ago, and but I'm also due my clinic appointment at the end of July.
Okay.
So I could catch her then.
Okay. Can you drop me an email? John can give you my email address. Can you just drop me an email and I'll pick that up, okay?
Okay.
But we are very live to it. You are absolutely right. It's a real frustration. It's a trap that arose due to the delay in getting this trial up and running, which is down to our good old friend COVID, actually, because it slowed everything down. And actually, I think the decision is, there are two options. One is to come off bezafibrate for a short period of time. That certainly makes you eligible for the trial if you're eligible otherwise. That there are pros and cons of that. We can talk about that. Or
okay,
we'll change the protocol.
All right, thank you very
Great
much.
Stuff. Yeah, I've got a question from Geraldine first. I don't know if you picked that up, Dave. Is pain in the upper arms related to PBC?
It can be. You can get muscle pains and you can get long bone pains. It's in the PBC 40, so people tend not to think about it. So you can get joint and muscle aches, absolutely. It tends to be linked to how active the disease is. The thing to watch out for, however, is so that tends to be not particularly problematic, but it can be something that's there. 3 things to watch out for. The first is there is a rare condition called polymyositis, which is a muscle inflammation, which is another autoimmune condition. It's not particularly associated with PBC, but that causes painful muscles. So, and that's something to mention when you next talk to a doctor, mention that. The second is polymyalgia rheumatica, which, although it sounds like polymyositis, is completely different, but also causes muscle pain. The classic sign for that is people can't brush their hair. Not that I would ever have. So it's always said to me that you can't lift your arm up to brush your hair. So that is associated with PBC weakly. So that can be a reason. And then the third one is to watch out for statins and fibrates. So as I want people.
It's frozen again.
on fibrates, as we've discussed. And there's a whole load of fuss about whether they do or don't cause muscle problems. The answer is they do cause muscle problems. And so that's something to discuss with your doctor if you're on fibrates or a statin.
Right, okay. I mean, mainly, oh, sorry, mainly when it's when my arm, when you're putting your arms out and upwards, it's the pain in the muscles.
Yeah.
So I did mention it to the GP, but she wasn't quite sure what it might have been. So,
okay.
And then it wasn't taken any further.
Okay.
But thank you anyway.
So those
give
are
me some
of those, if you're not on statins or fibrates, which I'm guessing you're not,
no.
then polymyalgia rheumatica is the one to watch out for.
Right, thank you very much for that. I do appreciate it.
Geraldine, this will be on our YouTube channel, and what Dave just said will be at about 92 minutes or something. If you want to scroll through to get the names right, if you're going to talk to your doctor, okay?
Lovely,
so
thank you very much, Pastor. Thank you.
It was Joan. Did you drop your hand? Yeah. Okay. So it's now Liz, and then Sarah.
And then sadly, I'm going to have to head off.
Yeah, we'll be as quick as we can, Dave.
I think it's probably answered itself anyway. It was just when we talked about the bezafibrate, is it the same as fenofibrate?
Good question. Very closely related. Both have been used in PBC. Historically, we tended to use fenofibrate for reasons of ease of use. A lot of the trial data in PBC is with bezafibrate. I think if I was starting on anybody now, I'd use bezafibrate. If somebody was stably on fenofibrate without any problems, I wouldn't change.
Yeah.
Great
Thank
stuff.
you.
Thanks for that, Dave. Sarah, you had a question? You need to.
Hi, yeah, it's just a quickie about the AMBER trial. Is that something that you would need to be near your hospital for?
No, there are centres across the UK doing it, but we can help people fit into that. There are centres across the country. Okay.
I'm in Exeter in Devon, so.
Wow.
That's fine.
That's a long way away.
Yes, I know.
Do you see Linley Wong?
I'm not. I'm just waiting to be referred to her, actually.
No, she trained with us. She's lovely. Okay.
Yeah, because I was under a different consultant, but I believe she specialises in. She's
a specialist in autoimmune stuff. She's really good.
But, yeah.
She's really, really good, and it's very nice. So there are ways of being able to do it. Okay. So
okay.
Real issue. We want to. Up to and including the company opening different centres. Okay.
Right.
Now, as you will know, historically, the Southwest has not had access to a lot of these trials, and that's not fair. And as you know, you may or may not know, there's a thing called the NHS Constitution, which says that people are have a right to be able to participate in research, and so the system is designed to help with that. So I think the thing to do is to there are quite a lot of technical criteria to do with elevations of blood tests and things like that.
Right. Okay.
That's for AMBER. There is going to be a follow-on trial, which is so. Without getting,
I'm quite stable, apart from the fact that I've recently been diagnosed with PBC, AIH PBC overlap.
Okay. So it's worth having a chat with Lynn Lee about it, and she gets information from us. There is AMBER is almost finished, and the follow-on trial is going to be much more broadly based. And at the moment, AMBER is for people who aren't completely controlled with steroids, which is a smallish group of people. The larger problem is people who are on steroids but want to get off them, who are stable on steroids. Right? Yeah. Okay. So you know what I'm talking about. So that's the problem: is people want to get off steroids. And in a sense, the disease is controlled, but at a price that's unacceptable.
I'm on steroids and mercaptopurine.
Yeah. So the next, son of AMBER will be a steroid withdrawal trial, where essentially you use the drug to allow people to stop steroids. It's the one they need to do. So we work really hard on the company to do that, because what we should be doing is saying this drug works better, and you shouldn't force you to have a disease flare up to make you eligible, just do a swap over trial. Okay.
Okay, thank you.
And the end point will be, can you get people off steroids with a stable disease? And honestly, we should have done these sorts of trials 20 years ago.
That's lovely. Thank you.
Okay.
Thank
Excellent. No more questions for our guest speaker?
you. No.
No. Well, you're in a rush to get away, Dave. Yes.
I forgot you were videoing it when I was quite so outspoken. I should have been less outspoken.
Well, we've made the point all along that it's your personal opinion.
Yeah.
You know, you made that point at the beginning, and we've repeated it, that it's your personal opinion.
And you must go and discuss all of these things with your clinicians. Blah blah.
Absolutely, absolutely. Well, I'll stop videoing it now because we're going to go on to the